Good morning, everyone, and welcome to this week's Grand Rounds. Before we get started, just a few housekeeping things. Please make sure your video is off and your mics are muted. Also, we ask that you hold your questions and comments to the end, at which time you can unmute yourself or use the chat box. Lastly, the CME information for today will be displayed during our presentation and will be periodically placed in the chat box. Today, our speaker is Dr. Jason Zucker, joining us from Columbia University for a presentation on 2021 STI guideline updates. Dr. Jason Zucker is Assistant Instructor in Medicine at Columbia University, Bigelow's College of Physicians and Surgeons, and Assistant Medical Director at New York City STD Prevention Training Center. He is an NJMS alumni and completed his combined medicine and pediatrics residency here, where he later served as chief resident. Dr. Zucker went on to complete a fellowship in combined med-peds infectious disease with a focus in sexually transmitted diseases at Columbia University. He has published dozens of peer-reviewed research articles and serves as a reviewer for many journals, including the International Journal of STDs and AIDS and the Journal of the American Medical Informatics Association. Dr. Zucker continues to make great contributions to his field through several grant-funded projects focused on HIV prevention and through mentorship of fellows and medical students. We welcome you and thank you, Dr. Zucker, for joining us today to give this presentation on 2021 STI guideline updates.
Good morning, and thank you very much for having me. And thank you for the introduction as well. The CME information is on this current slide. And while the CME information is up, let me just thanking Dr. Clapwell for having me today and Dr. Deber for inviting me. It's an honor to be here with so many friends and people I admire. And I'm just sorry I wasn't able to be there back in person in MSB. With that said, I'll get started, but we'll stick around at the end for questions or if anyone just wants to say hi. For disclosures, I receive funding from the NIH through NIAID, and I don't personally have any other disclosures. However, there's institutional research support to my collaborators from Gilead and Merck. So the objectives for today are to describe important updates to the 2021 STI treatment guidelines, discuss the rationale for these updates, and illustrate how to apply these guidelines to your practice. So to start with, we need to talk about sexually transmitted infections and why they are important. So many clinicians don't think about STIs nearly often enough, but they're another epidemic just like HIV that's increasing rapidly. Since 2015, there's been a 19% increase in chlamydia cases, a 56% increase in gonorrhea cases, and a 74% increase in syphilis cases, and a 279% increase in congenital syphilis cases nationwide. In addition to being prevalent, sexually transmitted infections are expensive, costing about $16 billion per year, with over $1 billion going to gonorrhea, chlamydia, and syphilis, the most common but easily treatable bacterial STIs. And these are 2019 numbers pre-COVID. The suspicion is that COVID may have actually made things worse. This is an article that we published describing the availability of sexual health services during the COVID-19 pandemic. And we found that throughout the country, and particularly within the New York and New Jersey regions, many sexual health service sites were closed. I'm not sure if I'm allowed to retrospectively dislike a graph I made back in April of 2020 at the height of the pandemic, but this on the right-hand side is a list of STI services. The blue bar is the percentage decrease in services in New York State, and the orange bar includes other states, including New Jersey. As you can see, all STI services decreased from 30% for services for newly infected HIV-positive individuals, versus over 80% decrease in offering STI testing for asymptomatic patients. And some of this data made it into a modeling exercise done in part by Julia Marcus at Harvard, who looked at STI and HIV rates in Atlanta. She found that if social distancing lasted only 3 months, but service interruption lasted 18 months, the total 5-year impact would be almost 900 additional HIV cases and over 57,000 additional STI cases. And this is important right now because social distancing is over, but STI testing has still not returned to baseline. Many clinics throughout the region are still closed or offering reduced services. So this is some of my local data that I wanted to share with you from an upcoming supplement in pediatrics. This is actually the number of gonorrhea and chlamydia tests by location. The emergency department at Columbia is the dark green. The inpatient is the sort of the light green that you can barely see, and then outpatient is the lightest green. And as you can see, STI testing dipped during the COVID pandemic and has not yet returned to baseline. This one shows the total number of gonorrhea and chlamydia tests since 2018. The top chart is for patients aged greater than 25 years of age, and the bottom chart are those less than 25. Nationwide, the biggest increases in STI cases have occurred amongst those aged 15 to 24, so those under the age of 25. As you can see in this top chart, those under age 25 had a big dip in services during the pandemic, but have almost returned to their baseline testing rates. However, for those under 25 years of age, those at highest risk of STIs, they continue to have a markedly decrease in rates of STI testing and diagnoses. It's only through resuming services that we can prevent a worsening of the STI epidemic. However, with that said, as we know, many services remain reduced. For example, 4 of the 8 New York City sexual health clinics remain closed, and many within New York City are operating at reduced capacity. There are limited options for patients when it comes to their sexual health care, and we need to make sure that all of our providers are ready to provide care when patients need it. And we may actually be starting to see the effects of this reduction in services. I apologize, I don't have New Jersey data to show. They haven't been published for 2021 yet. But a few weeks ago, I had the honor to present with Julie Schillinger from the New York City Department of Health, and she shared this important slide with me. This reflects the data we're seeing in New York, and she compared 2019 to 2021 because the feeling was 2020 testing was artificially down. And the data showed that primary and secondary syphilis was up almost 9.5%, with females more than males increasing, and that female gonorrhea was up a startling 23.6%. The sense is that these are being caught more often because gonorrhea and primary secondary syphilis are frequently symptomatic. And so even during the pandemic, patients will come in and ask for testing. Unlike chlamydia, which is frequently asymptomatic, and so may be down because patients are avoiding or postponing needed asymptomatic testing. This may portend worse numbers to come. So as I've said, the 2021 STI guidelines have been updated. They were updated in July. And what I haven't mentioned is that it's the first update since 2015, which is a really long time in medicine. They were supposed to be updated in 2020, but were delayed due to COVID. And because of that, they actually released gonorrhea updates in December and then released the remaining guidelines in July. The guidelines are 192 pages, include 1,455 references. So because they hadn't been updated since 2015, there are a lot of major changes. So just to set expectations, because we only have about 45 to 50 minutes, I'm going to only talk about the common things that you're likely to see in your practice if you look for them, with a focus on changes from the prior guidelines. I'm not going to talk about implementation, but I'm happy to help if anyone has questions about that after the talk. Please feel free to put any questions you have as we go along in the chat. So I have a few sample patients we're going to use today. These are all based on real patients who come to our clinic. In the interest of time, I'm not going to be going through all the details about them, but just using them to provide some context for today's discussion. So these are 2 very common cases we see in our sexual health clinic. Jack is a 22-year-old bisexual male who comes in complaining of dysuria and penile discharge. Jill is a 24-year-old bisexual female who presents complaining of dysuria and vaginal discharge. So the first thing we should be planning to do for patients like this are to take a detailed and comprehensive sexual history. Sexual health can greatly impact overall quality of life. The health impacts of STIs can range from irritating to life-threatening. Discussing a person's sexual health offers the opportunity for counseling and sharing information about behaviors that may increase STI and HIV risk. And it's recommended that a sexual history be taken as part of routine healthcare, as well as when there are symptoms or physical exam findings suggestive of STIs. A sexual history allows you to provide high-quality patient care by appropriately assessing and screening individuals for a broad range of sexual health concerns. However, when we survey residents, only about 30% report taking a sexual history in the majority of their patients. And it's our job to help improve that. So for that reason, I do want to highlight this guide, which was updated in concert with the guidelines. And it actually provides you with a sample of the discussion points and questions that may be asked. One example I really like that I feel like is really changing is the question about, do you have sex with men, women, or both? They've really worked to update sexual history taking to make it more gender neutral. Questions like, what is or are the genders of your sex partners? And are you currently having sex of any kind? There's a lot of great tips and language in this guide that you can use, and I really hope that everyone will read it and encourage their residents to read it as well. So after taking a sexual history, you'll recommend some testing for JAK based on what you've learned. So I work in a sexual health clinic primarily, and we do a pretty standard workup for everybody who comes into our sexual health clinic. This includes HIV testing, 3-site gonorrhea chlamydia testing with a gram stain if able to, an RPR for syphilis screening, and an offer of HIV prevention services. And this is really the minimum workup for a bisexual male presenting with STI symptoms or at risk of STIs. So I want to start by highlighting extra-genital testing. In previous iterations of the guidelines, it was recommended to do extra-genital testing only for men who have sex with men based on reported behaviors. However, now the guidelines have been updated to consider rectal chlamydia, gonorrhea, and pharyngeal gonorrhea for females through a shared decision-making approach based on their sexual history. Extra-genital testing can also be offered to men who have sex with men who do not report exposure at these sites, after a detailed explanation and due to unknown underreporting of risk factors. What they're really saying is that they're encouraging the expansion of extra-genital testing because we're learning more and more that patients can have a negative genital urinary test, but a positive test at another site. And as you'll see as we go through some of the data, identifying the site of positivity really helps determine the appropriate treatment and follow-up management. So there's this emphasis on extra-genital testing. And so they cite this study in the guidelines, but it's really one of several now, including a national one from LabCorp that all come to similar conclusions. In this particular study that ran from January 2012 to October 2014 from the Kansas City Department of Health, they looked at over 9,600 encounters. And what they found is that in most cases of gonorrhea and chlamydia in men who have sex with men would have been missed if extra-genital testing had not been performed. And that a third of cases of gonorrhea and chlamydia in men who have sex with women and women who have sex with men would have also been missed if only genital urinary testing had been performed. So this is the table from the paper, and I've tried to label it, and we'll also walk you through it. The left-hand side is gonorrhea. The right-hand side is chlamydia. The top row is pharyngeal infection, and the bottom row is rectal infection. The darker color gray are patients who had the infection only at an extra-genital site and were genital urinary negative, while the lighter gray color patients had infection in both the extra-genital and the genital urinary site. And so as you can see in men who have sex with men, the black color predominates, meaning that the majority of patients only had an extra-genital positive test with a negative genital urinary test. Meaning if you tested urine only, you would have missed the diagnosis of a sexually transmitted infection in those patients. But even among women who have sex with men and men who have sex with women, a substantial portion of cases, about a third, would be missed if extra-genital testing was not performed. So hopefully this slide in particular highlights the importance of extra-genital testing in not just men who have sex with men, but in all patients, if we want to ever be able to diagnose STIs appropriately and make a dent into the STI epidemic. So going back to Jack's workup, Jack underwent a gram stain from his urethral discharge, and we found that he was positive for gram-negative intracellular diplococci. So again, he's a man who has sex with men, coming in with dysuria with a positive gram stain, which is most consistent with gonorrhea. So the next question is, what should we do for Jack now? And here's another area where the guidelines changed. In the previous iteration of the guidelines, we always started with ceftriaxone 250 milligrams and azithromycin 1 gram once as dual therapy for gonorrhea treatment. One of the major updates to the guideline is actually a recommendation to change the dose of ceftriaxone to 500 milligrams without azithromycin, and to consider doxycycline if chlamydia infection has not been excluded, but we'll get back to that one shortly. So the new gonorrhea treatment guidelines increased the dosing from 250 to 500 milligrams, and actually up to 1 gram if the patient is over 150 kilograms. And they're no longer recommending dual therapy with azithromycin. And they also recommend that you should consider 7 days of doxycycline if chlamydia infection has not been excluded. We're going to talk about chlamydia in more detail in just a couple of slides. We also have 3 alternative regimens now. The first is our traditional regimen for patients with true allergies to ceftriaxone or other beta-lactam antibiotics, which is gentamicin 240 milligrams IM plus azithromycin 2 grams. The second is Syphilis, 800 milligrams as a single dose. For those who remember Syphilis from previous iterations of the guidelines, this is a higher dose of Syphilis, and resistance has come down since we're using it less. However, while this is a possible regimen, we know that Syphilis does not provide as high or as sustained blood levels as ceftriaxone. It also demonstrates extremely limited treatment efficacy for pharyngeal gonorrhea, and therefore we do need to take care when using it. Finally, there's considerable quinolone resistance among gonorrhea, but the CDC is really pushing resistance-guided testing. And so if you're lucky enough to be a site that has GERD-A testing, which is a marker for quinolone resistance, and it's negative, using ciprofloxacin is a reasonable option. At least for now, very few places have that option, but it's expected that more will in the future. So that's a pretty significant change. So why make this change? What was wrong with the old way of treating gonorrhea? There's really two categories of reasons. The first is antimicrobial stewardship, and the second is pharmacokinetics and pharmacodynamics. Since publication of the 2015 STD treatment guidelines, concerns regarding antimicrobial stewardship have increased, especially regarding the impact of antimicrobial use on the microbiome, and data indicating azithromycin resistance for gonorrhea and other organisms. If you look at this chart here, the darkest blue boxes are resistance to gonorrhea, and since 2013, azithromycin resistance to gonorrhea. And since 2013, it's increased more than 7-fold in just 5 years. So the first reason for removing azithromycin from the guidelines is that it's less likely to provide an added benefit in treating gonorrhea, and we're developing more as we develop more resistance to it. The second is rising resistance in other pathogens, things like Salmonella, Shigella, Campylobacter. We're seeing more and more nationwide resistance to these pathogens. And these pathogens are actually incredibly common. In one study we did pre-COVID in a population of men who have sex with men, at least one pathogen was detected among 45% of enrolled participants. And so reducing azithromycin resistance to the common pathogens like Salmonella, Shigella, and Campylobacter is another reason for wanting to use less azithromycin. The third reason is the selection for non-macrolide resistance. So in this study of mass distribution of azithromycin to preschool children twice yearly in sub-Saharan Africa, azithromycin was shown to reduce childhood mortality, but at the cost of amplifying macrolide resistance. But it wasn't just macrolide resistance. Continued mass azithromycin distribution also selected for non-macrolide resistance, including resistance to beta-lactam antibiotics like ceftriaxone. So this is really why they removed the recommendation for dual therapy with azithromycin. The goal is to reduce the amount of azithromycin used. But why did they increase the dose of ceftriaxone? So the second major category is pharmacokinetics and pharmacodynamics. Pharmacokinetic and pharmacodynamic modeling has affected our understanding of optimal antimicrobial dosing for many pathogens, including Neisseria gonorrhea. One thing we know is that we're seeing a rise in the minimal inhibitory concentration, or MIC, for ceftriaxone to gonorrhea worldwide. The MIC is the lowest concentration of an antibiotic that inhibits the growth of a given strain of bacteria, and as the MIC increases, more drug is needed. Ceftriaxone levels need to be over the gonorrhea MIC for about 24 hours to be effective. There's actually a national surveillance network that monitors gonorrhea MICs, and while we haven't seen the MIC creep in this country that has been seen in others, we know it's increasing in other countries quickly. In Australia, they increased the dose of ceftriaxone to 500 milligrams almost 2 years ago. And in England, where they've seen several cases of highly resistant gonorrhea, they've increased to 1 gram without azithromycin. The second issue occurs in the pharynx. There are 2 reasons we're concerned about the pharynx in particular. The first is that the pharynx tends to be screened less often than other anatomic sites. And globally, most reported ceftriaxone regimen treatment failures have involved treatment of pharyngeal gonorrhea. Ceftriaxone concentrations also tend to be very variable in the pharynx. So since we know we need to be above the MIC for 24 hours, this variable concentration is really a big problem. And the hope is that increasing the dose of ceftriaxone may help overcome this issue. So now that we know how to treat gonorrhea, the question is always about follow-up. So unchanged from before is abstaining from sex until 7 days after completing treatment. We should always be assessing for treatment failure if persistent symptoms occur at 3 to 5 days with a culture with antimicrobial susceptibility testing and nucleic acid amplification testing. And a new recommendation is a recommendation for test of cure for all pharyngeal infections at 7 to 14 days. So one of the questions I always get asked is, do I really need to do extra-genital testing if I'm going to treat this person empirically? And one of the many reasons I say yes is that it changes your follow-up management. The recommendation for a test of cure at 7 to 14 days is different than if you would just have a positive genital urinary test. We are doing a test of cure at 4 weeks if patients are pregnant, and everyone should be rescreened at 3 months because rates of reinfection are high. And reinfection is really the most common reason people remain testing positive. Now, when we focus on a molecular testing period of 7 to 14 days, I always get a question about whether we're just going to pick up non-viable organisms. As we know, persistent non-viable organisms can cause false positive results, and this is more likely using modern molecular testing. However, reinfection from re-exposures are much more common for a persistent positive gonorrhea test. And if you look here, this is the RNA NAT, which is what I believe they use at university. And you can see that after 0 to 7 days after treatment, persistent positivity is about 8.7%. At 8 to 14 days, it's 2.2%. And at over 15 days, it's 1%. And so I always recommend retesting closer to the end of the 14-day window. But again, you would not expect too many false positives even at 8 to 14 days. So based on the gram stain, Jack was empirically treated with ceftriaxone, 500 milligrams times 1. His results came back positive for urine gonorrhea. Remaining testing was negative, and we'll come back to Jack again shortly. So Jill, who we spoke about earlier, came in with dysuria and vaginal discharge. She also got the same workup. We added in Trichomonas because testing for Trichomonas should be performed for women seeking care for vaginal discharge. And as a reminder, Trichomonas testing is only recommended for men who have sex with women with persistent symptoms who failed treatment for gonorrhea and chlamydia. So Jill also got a gram stain. Hers was positive for 10 WBCs per high power field, but no organisms were seen. I don't think we're doing a lot of gram staining in most practices, but they did change the cutoff for non-gonococcal urethritis, as you can see on the bottom left of this slide. But I want to highlight this case because the negative gram stain means that you really need to be thinking about non-gonococcal urethritis. And what's important to know is that we have some new pathogens. Chlamydia was and remains the most common cause of non-gonococcal urethritis. But we've actually added Mycoplasma Genitalium to this list, and it's more prevalent than even Trichomonas, and we'll talk a lot about that coming up. Neisseria meningitidis has also been added to the list, and really, and most importantly, an acknowledgement that about half of these cases of non-gonococcal urethritis may end up unknown and may be non-infectious in etiology, particularly in cases of cervicitis. So recognizing that we may not identify a pathogen and that these may actually be irritations and non-infectious etiologies is important. Chlamydia infection is the most frequently reported bacterial infectious disease in the United States. This means that numerically, the biggest change in the guidelines is the change in the treatment for uncomplicated chlamydia. Previously, we used azithromycin or doxycycline for the treatment of chlamydia. However, now doxycycline, 100 milligrams twice daily for 7 days, is the preferred regimen. It's important to know that azithromycin 1 gram has not been removed from the guidelines, but it has been moved to an alternative regimen along with levofloxacin. It's important to remember now that because of this change, doxycycline is to be avoided in pregnancy, and so azithromycin remains preferred in pregnant patients. And erythromycin is no longer part of the guidelines. So this is an extremely impactful change. So why did we make these changes for chlamydia? Well, the first reason is that microbiologic failure was higher among men, even at genital urinary sites. This was actually a randomized controlled trial comparing oral azithromycin with doxycycline for the treatment of urogenital chlamydia infection among adolescents in youth correctional facilities. The goal was to evaluate the non-inferiority of azithromycin to doxycycline. Because it was a correctional facility, treatment was able to be directly observed. The primary endpoint was treatment failure at 28 days after treatment initiation. 567 participants were enrolled. And in the context of a closed population receiving DOT for urogenital chlamydia, the efficacy of azithromycin was 97%, and the efficacy of doxycycline was 100%. These results, based on the pre-specified analysis, meant that the non-inferiority of azithromycin was not established, which I know is a double negative and confusing, but stated differently, doxycycline may be better than azithromycin as treatment for genital urinary chlamydia. But given how effective azithromycin was, this data alone would probably not be enough to change the guidelines. Treating rectal chlamydia adequately is also important, and probably the major reason for this change. Doxycycline has been found to be superior to azithromycin in 2 recently published randomized controlled trials with a 20 to 26% difference in efficacy. This first study was done in Seattle and Boston. It was a randomized controlled trial of 177 participants. 76% met the complete case definition. And the 7-day course of doxycycline, which are the blue lines going up, was significantly more effective than a single dose of azithromycin in the orange lines going down. This was further confirmed in this other study published last year from Australia. It's another randomized placebo-controlled trial, 207 participants, 83% met per protocol analysis. And again, a 7-day course of doxy was significantly more effective than a single dose of azithromycin. So doxycycline is clearly better for rectal infection, but does that matter to all our patients? Well, the answer is yes. Now, I said earlier that updated guidelines suggest that rectal screening can be considered for females on the basis of reported sexual behaviors and exposure through a shared clinical decision-making approach. But receptive anal intercourse is actually a poor indicator for the need for rectal treatment because it's not just sexual behaviors that matter. Rectal infection is not uncommon among women with genital urinary infection, ranging from 33 to 83%, regardless of behavioral risk factors. And this is thought to be likely due to autoinoculation from the urogenital site. If rectal chlamydia is inadequately treated, women are at increased risk for repeat urogenital chlamydia infection through autoinoculation from the anorectal site. So treating chlamydia adequately is important, and so it's an important reason that we made these changes to the guidelines. However, when choosing a treatment for chlamydia, you're really trying to balance the efficacy of doxycycline versus the ease of azithromycin. Access is one major difference. Many clinics and emergency departments may be unable to provide a 7-day course of doxycycline directly to the patient, while most can provide a single dose of azithromycin. Patients who are uninsured may be limited to what they can get in clinic or in the ED. And this challenge is magnified for adolescents and young adults. For example, in one study from Washington, D.C., they found that only 58% of adolescents who received a prescription for STI treatment filled it. Adherence is a second difference. It's obviously easier to take 1 gram once than it is to take a medication for 7 days. However, one thing that's important is to set our judgment aside. When the gonorrhea update first came out in December, there was a lot of concern about 7 days versus 1 dose. But I will tell you that in practice, I find that most patients can do it, and frequently the ones that can't will tell you. Additionally, in the recent randomized controlled trials, azithromycin performed so poorly that even in the context of imperfect adherence, doxycycline is likely better. Finally, confidentiality. Patients may value not having pills in the house. They may not want a parent or friend or roommate to find out, and being able to treat them at the point of care may be beneficial. So these are just some of the reasons to balance doxy versus azithro. In general, you will want to choose azithromycin in patients who are pregnant or may be pregnant, patients with a history or allergy or intolerance to doxycycline, patients that are unlikely to be adherent, and patients that are unlikely to be able to obtain doxycycline, and azithromycin is available at the point of care. This is our recommended approach. If there is suspected or possible chlamydia, it really should, this is our recommended approach. If there's a possibility of rectal chlamydia, it really should be doxycycline. If there's a possibility of pregnancy, it has to be azithromycin. And if neither of those is true, it's really a shared decision-making approach with doxycycline as the preferred agent. In terms of follow-up for chlamydia, again, patients should abstain from sex until partners have completed treatment or 7 days after single-dose therapy. One of the new changes is to consider repeat testing at 4 weeks for rectal chlamydia if treated with azithromycin due to lower efficacy. Again, we do a test of cure at 4 weeks if pregnant, and we rescreen at 3 months for reinfection. So Jill received doxycycline for 7 days. But the next question is, what else can or should we do for them? And that brings us to prevention. The updated guidelines really focus in on prevention. They actually have 6 sections, each with multiple subsections, but I'm only going to focus on 3 of them here. The first is HIV testing. HIV prevention starts with testing. For patients testing positive, they can go on to secondary prevention, undetectable equals untransmittable, and getting patients on treatment is a form of HIV prevention for their future partners. For patients testing negative, this is a great opportunity to discuss the potential need for PEP and PrEP and provide them education for the future. And yet, in spite of its importance in the HIV prevention cascade, we don't do nearly enough HIV testing, and missed opportunities are common. These are just some of the studies demonstrating missed opportunities for HIV screening, and the 2 in red were actually done at University Hospital when I was a resident with Dr. Sunimo and Swami Nathan, who I know are on. Don't forget about assessing and offering for PEP and PrEP. PrEP is what I spend most of my time on now, and can easily devote an entire hour to it if you let me. But in the interest of time, I'm just going to highlight that they're emphasizing these in the guidelines. Post-exposure prophylaxis is for individuals exposed to HIV within 72 hours. PrEP is pre-exposure prophylaxis, is a pill that can be taken daily or as needed and can prevent individuals from getting HIV as much as 99% when taken as directed. I'll also highlight that it's now a A-level recommendation by the United States Preventive Medicine Task Force to offer it to individuals at risk of HIV acquisition. So please think about it for patients at risk of HIV, both HIV testing, PEP, and PrEP. And finally, expedited partner therapy. So I said earlier that reinfection is the most common reason for recurrent infections. And so to reduce that risk for patients with gonorrhea or chlamydia, the CDC recommends management of sex partners, and expedited partner therapy or treating sex partners without seeing the partner is permissive. It's actually exciting that EPT is now permissible or potentially allowable in all 50 states and not prohibited in any. I've been giving this talk since about 2016, and it's been fun to watch this map update from having some prohibited areas to now where it's not prohibited anywhere. I'll say that while EPT is an option when managing sex partners, the primary goal is to get the partner to come into clinic for evaluation. Having partners come with patients when they come in for treatment is one way to get the partner to come into care. And it's great to get the partners in because EPT is more than just treatment. A visit's also a chance to provide a comprehensive sexual health history, including HIV and syphilis testing, and discussions around HIV prevention services. However, if partners are unable to come in promptly or at all, expedited partner therapy as a second option should definitely be considered. Previously, expedited partner therapy was available and recommended for heterosexual couples only due to the concern about HIV testing among men who have sex with men. While the data is limited on the effectiveness of EPT for men who have sex with men, it is now an additional option in cases where needed. The change was actually in part from an abstract done by Julie Schillinger in the New York City Department of Health. As I said, one of the major concerns about EPT amongst men who have sex with men was actually the risk of HIV and the lack of HIV testing. In a retrospective cohort study that of almost 4,400 visits by men who have sex with men who presented as contacts of patients diagnosed with chlamydia or gonorrhea, so contact tracing, 14% of visits resulted in a bacterial STI diagnosis other than gonorrhea or chlamydia, highlighting the importance of having patients come in for testing. However, among those with gonorrhea and chlamydia, HIV was diagnosed in only 8 or with 0.2% of all visits. And therefore, the risk of HIV was relatively low enough that EPT for men who have sex with men is now a permissible option. It's important to remember that states may have restrictions on who can get expedited partner therapy and what medications can be prescribed. I tried reviewing New Jersey state law last night, specifically this statute, which endorses expedited partner therapy, but it was unclear if there are any restrictions on what you can do. And if anyone knows that, please feel free to put it in the chat. According to the CDC, though, it's not just for heterosexual couples anymore. For MSM, shared clinical decision-making regarding EPT is recommended, meaning you should discuss it with your patient, talk about the options of having their partner come in, and if that's not an option, providing expedited partner therapy. In terms of providing EPT, we want to evaluate all sex partners. We want to empirically treat all partners in the last 60 days. If the patient has not had a partner in over 60 days, you can treat the most recent partner. And for expedited partner therapy, it's recommended for heterosexual men and women, and now men who have sex with men with a shared decision-making approach. In terms of treatment for expedited partner therapy, The treatment for gonorrhea is Syphilis, 800 milligrams by mouth once. For chlamydia, this is different than the rest of the guidelines, where there is no recommended and alternative agent. For chlamydia, the options are either doxycycline 100 milligrams twice daily for 7 days, or azithromycin 1 gram once. One of the challenges is that most studies of expedited partner therapy used azithromycin, so that's where a lot of the evidence lies. My method for this is a shared decision-making approach, is to encourage partners to take doxycycline when rectal infection is likely and pregnancy is unlikely. So I use doxycycline for most men who have sex with men. I will often use azithromycin for men who have sex with women. And for women who have sex with men, it really depends on how confident I feel about their pregnancy status and if I can speak with them directly, but often default to azithromycin when I can't. With that said, it's clear there's no easy algorithm for providing expedited partner therapy, which supports the shared decision-making approach being the best approach. So returning to Jill, Jill was treated with doxycycline. She wants to think about HIV prevention services like PrEP and declined expedited partner therapy. The following day, her labs returned positive for urinary and rectal chlamydia, and so it's good that she's taking doxycycline. But she also had a positive test for urinary trichomonas. So what else do we have to do? So in another change to the guidelines, the main difference is that the recommended regimen for trichomonas treatment for women is now metronidazole, 500 milligrams twice daily for 7 days, with tinidazole as an alternative therapy. The rationale by switching from a one-time dose to a 7-day course was largely due to this randomized controlled trial of single dose for 7-day regimen in women. It was a multi-center open label RCT at 3 sexual health clinics. 632 women were randomized to 2 grams of metronidazole in a single dose or 500 milligrams twice daily for 7 days. The primary outcome with trichomonas at test of cure at 4 weeks after treatment. Self-reported adherence and side effects were similar in both groups. And as you can see here, the 7-day group was about half as likely to be trichomonas positive at the 1-month test of cure, compared with women who received the 2-gram single dose. So the recommended regimen for trichomonas treatment for women is now metronidazole, 500 milligrams twice daily for 7 days. There is no published RCT on treatment for men, and so there are no changes to the treatment recommendation for men, and they can still be treated with a single 2-gram dose of metronidazole. Tinidazole is now an alternative therapy for both men and women. And one other major change that seems to be the most exciting to my patients is that the 2015 guidelines stated that alcohol consumption should be avoided during treatment with nitromidazoles. After further review, the 2021 guidelines state that abstaining from alcohol after metronidazole is not needed. Prior studies were really based on animal studies and case histories. Reports of adverse effects may be the result of alcohol or metronidazole side effects independently. Metronidazole does not inhibit acetaldehyde dehydrogenase like disulfiram, and therefore there's no need to abstain from alcohol while taking metronidazole. So back to Jack. Jack actually came back. He reported no sexual contact since his last visit. He received ceftriaxone for genitourinary gonorrhea, and chlamydia testing was negative. We did a repeat gram stain in clinic, which was now negative. And so once again, we think about non-gonococcal urethritis. So going back to non-gonococcal urethritis pathogens, chlamydia is most likely, but his previous testing at 3 sites was negative. Mycoplasma Genitalium is something that should be considered always in persistent urethritis and something to think about here. Trichomonas is more common in men who have sex with women, so it's also something to think about here. And so we tested him for both Mycoplasma Genitalium and Trichomonas. And he actually came back positive for Mycoplasma Genitalium. So I love MGen. In the last set of guidelines, it was categorized as an emerging pathogen, but now it's emerged and it's here. Since it's likely a new pathogen to many people, this slide is my everything you need to know about MGen slide. We should be thinking about Mycoplasma Genitalium in patients with persistent or recurrent non-gonococcal urethritis, cervicitis, persistent epididymitis, or proctitis, and consider testing in PID. Asymptomatic screening is not recommended as the consequences of asymptomatic infection are unknown. Testing is with an FDA-approved NAT, just like for gonorrhea, chlamydia, or trichomonas. And we're seeing a lot of resistance, as much as 44 to 90% for macrolides like azithromycin, and quinolone resistance up to 15%. Treatment, which we'll talk about in a second, is resistance-guided therapy. and sex partners should only be treated if positive. Mycoplasma Genitalium is surprisingly common. In this study, they looked at men with urethritis symptoms who were enrolled in 6 STD clinics, and they found that more than 1 in 4 men with urethritis were positive for Mycoplasma Genitalium. In terms of treatment, this is another example of using resistance-guided treatment. The recommendation is always to start with doxycycline to reduce the bacterial load. If macrolide sensitivity is available and it's sensitive, you can use azithromycin. Otherwise, the recommendation is doxycycline for 7 days, followed by moxifloxacin for 7 days. Currently, molecular testing for macrolide or quinolone resistance markers are not commercially available. And so in general, we do doxycycline followed by moxifloxacin. So Jack completed his 7-day course of doxy, followed by a 7-day course of moxy with resolution of symptoms. So back to Jill, who had previously declined partner therapy. She came back 2 months later with dysuria and abdominal pain. Her exam had cervical motion tenderness, consistent with mild pelvic inflammatory disease. And so the question is, how would we treat Jill? So here's the new regimen for PID treatment. It's generally ceftriaxone for IM or oral for outpatient and mild or moderate disease. It's ceftriaxone at the gonorrhea treatment dosing. Doxycycline, but for 14 days as opposed to 7. And the big difference is actually the addition of metronidazole. The previous guidelines recommended that you could or could not include metronidazole, but it's now recommended that metro be included in all cases of PID. For mild or moderate disease, you can do ceftriaxone, dosed for gonorrhea, along with doxycycline. And for severe disease, it's IV ceftriaxone, along with doxy and metro. So this was the study that provided data that led to the definitive guideline change. This was a randomized controlled trial designed to answer the question of whether adding metronidazole improved clinical and microbiologic cure in women with acute PID. They randomized 233 women to standard of care or standard of care plus metro. And the outcomes were symptom improvement 3 days and presence of anaerobic organisms in the endometrium. Clinical improvement was high in both groups, 83% with metronidazole and 80% without. And at 30 days, 97% with metronidazole and 90% without. What was noted is that endometrial anaerobes were reduced, pelvic tenderness was less common, and there was a weird decrease in cervical Mycoplasma Genitalium without an increase in adverse events. So their conclusion was that metronidazole should be added for all patients with PID, not just those with tubo-ovarian abscesses. And I think it's important to understand this study, as most patients did well in both arms. And so while there's clearly a benefit to metronidazole, some patients are unable to tolerate the metronidazole and doxycycline combination. And it's good to know that if we have to stop the flagell, it's good, outcomes should still be good. So Jill gets treated with IM ceftriaxone, doxycycline, and metronidazole with resolution of symptoms. So sadly, during COVID, Jack came back. In March, during the COVID outbreak, he went to urgent care with a rash and rectal pain. He was treated with ceftriaxone and azithromycin prior to the guideline release and sent home. So syphilis is a disease that we're seeing more and more commonly. I'm getting called about syphilis from someone at the hospital twice a week at this point. Understanding syphilis is all about the staging. First thing I want to highlight is that syphilis has an extremely long incubation period, up to as long as 90 days when you may test negative. This means that if a patient is exposed to syphilis, you pretty much need to treat them because you don't want to wait 90 days to find out whether or not they're positive. Primary syphilis is what's classically a single painless ulcer at the site of infection. And as a reminder, because it can be painless, it may not be noticed. If it's in the vagina, in the rectum, or in the mouth, you may not see it, and so patients may never know. We recently had a patient that we were doing a throat swab on and had a painless chancre on their tonsils. Next is secondary syphilis. These are systemic symptoms that typically we think of as a rash on the palms and soles. But anyone who's seen a patient recently know that we've seen a lot of unusual presentations, including flu-like symptoms, syphilis hepatitis, unusual rashes, and can look like almost anything. Latent disease, by definition, is asymptomatic, with early latent being in the last 12 months and late latent being just over 12 months. And I just want to highlight early neurosyphilis, early ocular, and early otic syphilis that can actually occur at any stage. They don't have to be just late. And we're seeing these more and more frequently as 3% in secondary syphilis. So one change to the guidelines is that we're seeing more and more atypical presentations of syphilis. This includes multiple, atypical, or painless lesions, most prominently in the rectum. And so while we think of it as a single painless ulcer or chancre at the site of infection, we can't rule out syphilis just because patients have multiple atypical or painful lesions. So going back to Jack, 2 months later, Jack felt like he was having a hard time hearing the TV. He went to the ED and was seen by ENT. They diagnosed him with asymmetric hearing loss and recommended an MRI. The MRI was normal and he was told to follow up outpatient. 1 month after that, he felt like he was having a hard time seeing the TV. He went to the ED where he was seen by ophthalmology and was diagnosed with panuveitis. They recommended a panuveitis workup and was told to follow up outpatient. So obviously I'm hinting that Jack is having issues with ocular and otic syphilis. One of the things they did in the updated guidelines was really enhance the clinical descriptions of these diseases. Ocular syphilis often presents as panuveitis, but it can actually involve any structure in the anterior or posterior segment of the eye and can lead to permanent vision loss. Otosyphilis typically presents with cochleovestibular symptoms, including tinnitus, vertigo, and central nerve hearing loss, and can result in permanent hearing loss. I bold permanent because we need to remember that ocular and otosyphilis are emergencies that require immediate treatment to prevent permanent vision or hearing loss. In terms of syphilis testing, there's not a good recommendation on who to screen overall. I don't love these screening recommendations, given that in the Northeast, we're in a high prevalence area, with syphilis increasing year by year. And so I generally recommend that HIV and syphilis testing be done for anyone that you're thinking about testing for sexually transmitted infections. In terms of treatment, there's no major changes to the treatment guidelines. Incubation, primary, secondary, and early latent still get 1 dose of IM penicillin. Late latent and latent of unknown duration get 3 doses of IM penicillin. And for early neuroocular otic syphilis as well, tertiary, it's still IV penicillin. While the guidelines have not been updated in terms of treatment, there are a few ongoing studies to keep an eye on that may change treatment management in the future. One is looking at 1 versus 3 shots of penicillin G for early syphilis, and another is looking at IV ceftriaxone for neurosyphilis, given its easier dosing. So as part of his panuveitis, Jack had an RPR sent that returned 1 to 128. He was called by the Department of Health and came to see me in STD clinic. So the big question is, does he need a lumbar puncture? And in the updated guidelines, the answer is really no. We're actually doing fewer lumbar punctures. The previous guidelines recommended a repeat CSF exam if the primary exam was positive. This meant that in cases of otic or ocular syphilis, even though you were planning to treat them, you needed to do a lumbar puncture to see if they also had neurosyphilis. In the updated guidelines, they took out the recommendations for repeat CSF exams if there's an adequate RPR response. And this is true for both HIV negative and HIV positive patients who are taking antiretroviral therapy. In terms of isolated ocular symptoms and no cranial nerve dysfunction, a CSF exam is not necessary. And for otic syphilis, the CSF exam is never necessary. And so in this case, he does not necessarily need a lumbar puncture since he didn't have any specific cranial nerve dysfunctions. So we actually had a midline catheter placed at home for him, and he improved after 14 days of IV penicillin. I tell you that when I called the ED about possibly sending him in for PICC line placement, they had another patient also with ocular syphilis in the ED at the same time. I don't have a particular case for this one, but I did want to highlight a couple of things about genital herpes, which is becoming a bigger and bigger issue on the internet and Twitter and Instagram. Genital herpes is a lifelong viral infection. Clinical diagnoses can be difficult because of the self-limited, recurrent, painful, and vesicular ulcerative lesions are absent in many patients at the time of clinical evaluation. In general, the goal is to make the diagnosis by detecting HSV from the genital ulcer lesions with PCR. Viral culture is not particularly sensitive and is most useful when looking for resistance. I think one of the things the guidelines did really well and is worth reading is try to explain when HSV serological testing is helpful. It's useful in patients with recurrent or atypical genital symptoms with a negative HSV PCR. It's useful in patients with a clinical diagnosis of genital herpes without lab confirmation, 12 weeks after suspected acquisition, or if a patient's partner has genital herpes. It may be useful in patients at higher risk for infection and patients living with HIV, and it's not useful in screening of the general population. They also now recommend a 2-step serologic testing to reduce the rate of false positives. starting with 1 and EIA, which is also often falsely positive with low index values, and then confirmation with a second test that uses a different antigen. I'm not going to go into this section in detail, but when you have a patient who tests positive for HSV, it can be incredibly stigmatizing. Counseling of patients with genital herpes and their sex partners is really crucial for management, and the updated guidelines provide a lot of counseling guidance on asymptomatic and symptomatic HSV. The goals of counseling include helping patients cope with the infection and preventing sexual and perinatal transmission, and there's about 2 full pages of guidance available in the updated guidelines. And so in summary, we talked about extra-genital testing for gonorrhea and chlamydia being emphasized, and to consider Mycoplasma Genitalium for persistent symptoms. In terms of treatment changes, we've increased the dose of ceftriaxone to 500 milligrams, as well as weight-based dosing for those over 150 kilograms. For chlamydia, we've made doxycycline 100 milligrams for 7 days the preferred regimen. For trichomonas, metronidazole for 7 days is now the preferred regimen in women. For Mycoplasma Genitalium, resistance-directed sequential treatment. For PID, we now add metronidazole routinely. And for syphilis, we no longer need an LP for ocular without cranial nerve deficits or otosyphilis. For prevention, we have more limited expedited partner therapy, and we support expedited partner therapy for MSM. Cefixime for gonorrhea, expedited partner therapy, and PEP and PrEP are emphasized. And just as a reminder, I'm from the New York City STD Prevention Training Center. We're here at Columbia. And we have some resources here. And I will put up the CME information. Any questions?
Dr. Zucker, thanks so much for a really great presentation and update on these guidelines. We have a few minutes for some questions. I'll definitely look forward to Dr. Swaminathan if she wants to make some comments. But while we're waiting for that, I was struck by your earlier slide where you noted that the differential between people above and below the age of 25 in terms of the testing and how that has not recovered in the younger groups, the adolescents and young adults. And I wonder if you can expand upon that. I mean, is it a function of telehealth? Are we not getting people in? Are they identified in different kinds of healthcare environments as compared to the older folks? And what can we do about that?
So I think some of it has to do with health needs. You know, younger people outside of vaccinations don't have a lot of health needs. They don't have diabetes, they don't have high blood pressure. Many don't have primary care providers and routinely use, publicly available sexual health services, which are frequently closed. During the pandemic. I think older patients tend to have more primary care physicians, have more medical problems, need to come in for more visits. And so we're making more routine visits during the pandemic than younger people were.
Thanks very much. A question about any recommendations on extra-genital HPV screening?
That's a great, is that Dave? Thanks, Dave.
It is. I guess it's Dr. Sanino.
There were no recommendations about extra-genital HPV screening in the guidelines because we don't necessarily know what to do with it. The continued recommendation is to vaccinate aggressively and to consider vaccinating up to 45 now, so we can vaccinate for HPV much older than we could before.
Thanks. From Dr. Verghese, the need for LP or eye exam in asymptomatic patients with high syphilitic titers. What would you recommend if they have high syphilitic titers greater than 1 to 128?
Yeah. So I no longer recommend, I used to send all these patients to the ED for a lumbar puncture. I no longer do. The reason for a lumbar puncture before, if you're confident in the diagnosis that you suspect they have ocular or otic syphilis, and you're going to treat them for 14 days, there's really no reason to do an LP anymore. The previous guidance for an LP was based on needing a repeat LP if the first one was positive. Now it's really just about following their titers over time. And so I don't LP almost any of these patients anymore.
Thanks very much. Dr. Swaminathan, any comments about how we're doing and any impact of these updates on our STI program?
Thank you so much. First of all, I need to acknowledge Dr. Zucker for an outstanding lecture. I think, it was to cover so much topic in such a short time, so great job with that. New Jersey, while I've been a New Jersey resident, has been playing catch up with New York City. that being said, Dr. Taha just started an STD treatment center within the ID practice, certainly not to the extent that you have in New York City. The one question I have with respect to, serology for syphilis, here we still do RPR with reflex testing, but many states, and I think even including New York City, are actually doing the reverse.
Mm-hmm.
So do you want to comment on that?
Sure. So we actually still do the traditional algorithm. Many places have moved to the reverse algorithm where you start with an EIA or CIA test. We're starting with an antibody testing and then only doing RPR testing in patients who test positive. It reduces the amount of false positives. I will say that it really depends on your population. Now, we've been experimenting a little bit with moving to the reverse algorithm here. And in our population, in our HIV prevention clinic, for patients who've had syphilis before, they'll all test positive on the screening test. And so there is not a big benefit to making that switch. In other populations, like pregnant women or populations that may have lower risks of syphilis, you certainly will get less false positives with the new switch.
Thanks.
Thank you.
A question from Dr. Della Piazza about EPT. If you can comment on how it is operationalized in your clinical experience, especially with electronic medical records and treatments.
I don't know if Dave or Kristen put her up to this question. So I've been fighting with Epic for about 3 years to try to get EPT entered into the electronic medical record. The way we're currently doing it here and the way the CDC would like it to be done is we give out in our sexual health clinic partner packs. And so we can give the medications directly to patients. That's the preferred way. A lot of settings can't dispense medications like that, including the emergency department. And so currently in New York State, almost everybody is doing it using paper prescription pads. There's actually an exception in New York to the electronic prescribing law that allows you to use paper prescriptions for EPT. Obviously, that's not so practical, especially if the patient's already left the clinic. Trying to get them to come back to pick up a prescription for EPT when you can send their medications to the pharmacy is just never really going to be successful. And so I've been working with a couple of different people across New York State to try to get it put into Epic, and we've been working on this for several years unsuccessfully. We're currently writing New York State guidelines on how EPT should be implemented, and we're going to put this in there. But I don't have a good answer for you yet, Michelle. But once we figure it out, I'm happy to let you know.
Yeah, that's great. That's so helpful. A question from Dr. Weiss regarding about how firm the evidence is regarding Mycoplasma Genitalium that it causes symptoms.
So I think the evidence that it causes genital urinary symptoms and potentially cervicitis are pretty strong at this point. There was a systematic review that was pretty good that really looked at those areas in particular. I think the evidence that it causes proctitis is a little weaker. They say it does because they found it in cases of proctitis where they couldn't identify another etiology, but it wasn't as strong as the evidence for genital urinary and cervicitis in MGen. In terms of the percentage of people it causes symptoms, and I don't think we know. It was an emerging disease just in 2015. We're learning a lot about it currently. And I think in 5 more years, we'll have a much firmer answer on sort of what percentage of people are symptomatic and know a lot more about it than we do today.
Thank you. Dr. Zucker, I think our time is up for this morning. So I want to thank you again for really a fantastic presentation and talk, and really updating all of us on the understandings around sexual health and STIs. Thank you to everybody who joined this morning, and I hope you learned as much as we did. So have a great day, and thanks again, Dr. Zucker.
Thanks for having me, everybody.
Be well.